Okay, here we go. And so this slide, so have your slides out for the following two lectures. Have your slides out for cardiac conditions with regards to hypertension, and also have it out for myocardial infarction, because this will be a joint little lecture. It will go from the one topic right into the other, and we'll go right from hypertension right into coronary artery. Okay, so what we're going to talk a little bit is we're going to talk about hypertension in this lecture. We'll talk about, and you won't necessarily have this slide on yours, but just to let you know how we're going to do, we're going to talk about hypertension first. We're going to talk about coronary artery disease, and under coronary artery disease, there are three divisions that you need to know, three specific illnesses that fall under the general category of coronary artery disease, and that is acute coronary syndrome. We'll also talk about angina pectoralis and myocardial infarction. Congestive heart failure is part of the cardiovascular lectures. This one has already been posted, and it is narrated by Anagel Serrano, the professor from the other section. Okay, we're sort of trading off between the two of us right now, who's doing lectures for both sections. So this is already posted in a separate lecture. Today, just in this online video, we will be doing hypertension and coronary artery disease. So let's get started. Hypertension. So basically, we're going to be talking about when your blood pressure gets too high. All of these we'll be talking about. We will be speaking of normal adult blood pressures, and this lecture will be primarily linked to adult blood pressures. When you go to pediatrics, there will be different guidelines for different levels, because pediatrics blood pressures are typically lower, so the thresholds will be different as well. So for this lecture in particular, we're just talking about adult blood pressures and when they get too high. So in particular, you have to review a few things and keep a few things in mind. What a systolic pressure is, what a diastolic pressure is. So systolic is the highest it will go to. Diastolic, this is what your heart is pumping at resting. There's also something called a pulse pressure and a mean arterial pressure as well. All of these together, we see they're influenced by a number of things. They're influenced by stroke volume. Okay, so this is the amount of fluid by volume that is pumped out every time the heart pumps. This is a bit of a review, because the stroke volume we talked about already in anatomy, and you've already been tested on that in anatomy. Also inflected by the rapidity, or how fast the heart is beating. Again, we spoke about this in the anatomy course, and when you talked about an anatomy, ejection fraction and things like that. This is part of what is going to either have an effect to increase or decrease your blood pressure. And also the elastic properties of the heart. So how well does the heart actually beat? How well does that heart actually contract? Is there anything influencing the contractility of the heart muscle? That's what we talk about when we are talking about elastic properties of the heart. How much can that heart muscle expand, and how well can it contract? And resistance of blood in the blood vessels. So this is when we're talking about when the blood gets out into your body, it's out of the heart, it's going into the tissues. Is there resistance in the peripheral blood vessels, leading to those capillary beds, leading to that area where you are exchanging your oxygen and carbon dioxide at the cellular level? If we have too much resistance, or too much I want to use the word occlusion, but let's see, if we have too much resistance or too much constriction in those blood vessels, leading to a vascular bed. Okay, if it's too hard to push blood through a vascular bed, then we would say that the peripheral vascular resistance, PVR, or the resistance of the blood in the blood vessels at the level of the capillary beds, is high. Or we can say PVR is low. But we call that peripheral vascular resistance. How hard is it for you to push that blood through that capillary bed? Arterial blood pressure. You can review this on page 422 and 423. This is the force that moves blood through the arterial system. This is a little bit of review from anatomy as well. There's contraction and relaxation of the left ventricle. In anatomy, we went through how that contraction and relaxation occurs, and these are determined by a number of factors. Usually they will lead to the systolic and diastolic components of a BP. So a lot of this we talked about already in anatomy, and this is why it is considered a little bit of a review. Now, we also, from anatomy, reminding that we have neural mechanisms for changing how certain things occur, either with regards to the heart or with regards to the peripheral vascular resistance. Remember, we have neuronal mechanisms, remember, located in the medulla or the pons. This is back to anatomy again. And you also have the autonomic nervous system, where you have intrinsic and extrinsic reflexes. You also have the renin-angiotensin system under hormones or hormonal mechanisms. Okay, and in particular we have the angioretention with the kidney, and we have vasopressin as well, released by the posterior pituitary. Excuse me. And just another remembering back to anatomy how that actually works as well. All this changing, all this change that will happen when we talk about the angiotensin system will change how you have changes. The ultimate changes will be the vascular increases in the vascular volume on one side, and increase in arterial blood pressure, and it will also cause constriction. You're going to see this in pharmacology. Okay, so this is where the stuff starts to link together. We talked about this system in anatomy. We didn't talk too much how it screwed things up, but we talked about, here we have angiotensin 2 doing the following here. Through angiotensin 2 basically causing constriction of blood vessels. You're going to talk about in pharmacology where if you block on angiotensin 2, either by not letting it be produced or by blocking how it maps onto receptors in that vasculature, how you can actually stop this pathway right here. So this is where things all start to come together, and you're going to see links like this is where you're going to see all the linkage happening between anatomy, pathology, and pharmacology in the next few lectures. This is why semester 2 gets more difficult as the semester goes on. But if you think about it and you know your anatomy and know how that works, then this isn't too far off the mark. Okay? Okay, so hypertension represents an elevation in the systolic and or the diastolic. It's not just one or the other. It's not both. Okay, it can be one or the other, or it can be both. But as if you have your systolic or your diastolic increase too high, beyond what's considered normal beyond its norms, then it will actually be considered high blood pressure. It's not just both; it's one or the other, or both. Okay, it's the most leading common cause for illnesses within leads to other health problems, leads to risk for other cardiovascular disorders. That's what CV stands for. It's more common in young men, and in general happens more in men and women. Why? Well, is that because we just live horrible lives as males? Is it because of the testosterone in our system? Is it because of the Y chromosome? Or is it because for the last 50 years, all the data we've collected has been regards to males in the workforce and men smoking? Don't know. But right now, as we know, we have men more than women actually are at risk for hypertension. The limits of how it will be, of what is considered hypertension is going to be discussed in pharm class, because it's going to directly relate to how you actually then and what kind of treatment you actually go for in pharmacology class. So limits of what the BP will be discussed in your pharm class, and you'll need to know those for your pharm class. So the pathophysiology of hypertension. So when you have a normal regulation of your BP is dependent on two things. It's dependent on the cardiac output, okay, and it's dependent on SVR. What is SVR? SVR, cardiac output, and what is SVR? Does anybody know? Systemic vascular resistance. Oh yeah, how much your heart is pumping out, and how hard it has, and what sort of resistance, or the systemic vascular resistance. Okay, how much is the heart pumping out? What's its capability, and how much is it pumping out? And then how much pressure does it have to overcome in the in a capillary bed or in the peripheral capillary beds? So Your blood pressure is a combination of these two things. Hypertension is caused primarily by an increase in cardiac output or an increase in this, so you can have total output increase, or you can have the vascular resistance increase as well. It can be both increasing, which will lead to an increase in BP, or if you only increase one, then you will increase the BP as well. You can increase cardiac output, it'll increase this, or you can increase the resistance, and that'll increase it as well. Cardiac output, it is increased by any condition that the heart rate or the stroke volume being pumped out of the left side of the heart is increased. The systemic vascular resistance is that force opposing it in a capillary bed, and the ease of the ability of actually to be able to move that blood through capillary beds and perfuse your tissues. So it's almost, another way to think of it is how easy is it to perfuse your tissues. That's another way to consider vascular resistance. The peripheral resistance is increased by can be increased by some other factors, such as not just how hard the heart is pushing or how contracted the blood vessels are in your capillary beds, but it could be because your blood is really thick. Okay, it's much easier to move water than it is to move honey. Okay, because it's thicker. So if you increase the blood viscosity, then you're going to increase your blood pressure. If you decrease vessel diameter, that's where you can get vasoconstriction occurring. You can increase your peripheral vascular resistance in those two ways. I believe that there is an animation that we have posted for you on YouTube. It's by Khan Academy. That's the one that we would prefer the two of you, that you guys watch for this one. You can watch these other tubes if these other two if they're still available, but we would suggest looking at the one from Khan Academy. It is quite good. And it's going to look like this one right here. So it's going to look, when we look at something from the Khan Academy, what we've posted, and this is just a way, it's kind of nice to look at it, and he will actually do the drawings as he goes through from the very beginning. Now, this brings us to certain types of hypertension. Notice we're not getting into numbers, we're not getting into major treatments and everything. That's left for pathology, for pharmacology. And here we will talk about something called primary, or we call essential hypertension. And this is basically where you have hypertension that is occurring without the evidence of any other disease condition. So you're going to see that somebody, for example, we will see as we go through the semester, somebody who has kidney failure will have hypertension. But if you took away the kidney failure and the kidney failure wasn't there, would the person have hypertension? No, they wouldn't. So that would be called secondary hypertension. These primary hypertension basically means there's no other, and you're going to look at it going, diabetes, but diabetes is a disease. Yes, but it increases your risk factor. It doesn't mean that not everybody who has diabetes gets hypertension. As we will said over and over through this course, it's an uncontrolled diabetic who will get the secondary sort of problems. So diabetes will increase your risk of getting essential hypertension, but it doesn't necessarily mean that you will get it. You might get here's one for you to twist your mind. You might get secondary hypertension because you had diabetes that led to kidney failure, and that kidney failure raised your hypertension. Okay, I know that's where this gets sort of crazy. But if we look at primary hypertension, which means no other evidence of an underlying disease state, we have basically your family history. So this is getting into your genetics. You know, how screwed up are you based on what your parents gave you? There is an ethnic factor or race that has to play in it, I believe. And we'll see this through the course of the semester, where, for example, people of East Indian descent seem to be at a higher risk for example, diabetes. We will see African people of African descent higher at risk for hypertension. So there is certain things. Those are just two examples, but we will see that there is a higher risk for certain type of ailments to follow certain ethnic patterns. Age, as you get older, things start to break down. Older, and every day and every way, I'm getting closer to hypertension and a stroke. Diabetes becomes a risk factor that increases that you can get hypertension due to that. High salt intake, so dietary intakes, general obesity, and excessive alcohol intake or smoking. These are not considered disease states. Okay, although there may be some argument that obesity is considered a disease, but it is not one of the pathophysiological diseases that we know of. Again, not everybody who is obese has hypertension, okay, but puts them at risk for it. So this is why we call, if you have these risk factors, you are at risk of getting primary hypertension. Secondary hypertension, as I stated, this means that you have an underlying, the hypertension comes secondary or happens because you have an other underlying disorder. Kidney disease. This is a big disorder. You get rid of the kidney disease, no hypertension. Adrenocortical disorders, coarctation of the aorta, and being on oral contraceptives, you will get secondary hypertension due to this. Okay, clinical manifestations. Most frequently it is asymptomatic, okay, which means it's insidious. The term it's insidious means sneaky and evil, okay, for those of you who actually watched the movie Insidious. Okay, I'm not sure if they use the definition correctly for the title for that, but we basically mean something that's sneaky and you really don't see it coming, and that's what the word insidious sort of implies. Asymptomatic basically means no symptoms. Asymptomatic. So frequently no symptoms come with the hypertension, and doesn't mean all the time, but frequently no symptoms, and it's insidious means it becomes severe and we end up getting target organ disease, okay, based on the fact that the hypertension is increasing. Severe hypertension, that's what HTN stands for. Severe hypertension you may experience a variety of symptoms secondary to the effects of the increase in BP in various organs. So this means you might actually end up having the symptoms that occur are symptoms that occur to damage that are occurring to certain organs. And usually we will see this, and if we do get any symptoms that are directly related to the hypertension itself, we usually see fatigue, decreased activity, dizziness, palpitations, angina, and typically headaches as well. We will see headaches happen in patients. Just had a patient on the weekend who he was a teenage patient, had hypertension. What was he dinging off at? Somewhere around 168 on 110, something ridiculous like that for a 14-year-old. He had massive headaches that were going on with it. So headaches, nosebleeds, dizziness, they are not more frequent in people with hypertension than in the general population. But if you've never had, let's put it this way, if you've never had a headache before or a nosebleed and then you get hypertension, it could be because of the hypertension. Now when we say target organ damage, what the hell are we talking about here? The heart. So when we say that the blood pressure has been constantly or consistently increased, what is that going to lead to? That's going to lead to atherosclerosis. We talked about this. When we talked about atherosclerosis in the previous lecture, we said damage occurring to the endothelium of the vasculature. What's going to do that? Well, stress on it. If your blood vessels have higher blood pressure in it, there's a higher risk of damaging those endothelial cells. It can lead to atherosclerosis. You get atherosclerosis building up, and that increased workload on the heart can also do something else too. So we've got atherosclerosis that can lead to increased peripheral vascular resistance. The second thing that can happen is the increased workload on the heart can cause left ventricular hypertrophy. That means an increased growth of the heart muscle on the left hand side, specifically the left, not the right, the left. Why the left? Because the left is pumping out. You've got peripheral vascular resistance, so it has to work harder. If you're having right ventricular hypertrophy, what is the right side of the heart pumping to? The lungs. So there would have to be increased, if you're having right hypertrophy, you would have to have some sort of increased resistance happening in the lungs. Not the most common thing that you're going to see in a lot of people. So, target organ damage, left ventricular hypertrophy. Left one is the big one that happens with hypertension. Okay, now you're saying, hey, what's the big deal? Why is it a bad thing to have your heart muscle grow thicker? Well, there is a bit of a problem with that, and the problem with that is, let me do something here. Oh, I made to draw something. Here we go. So let's draw your heart. I can't do this. I could never do this in class. Here's your. I know. I drew the left side a little bit smaller than the right. That wasn't my intention. Just deal with it for a second. Okay. So let's say this, and let's just very schematically, because this is just for concept. Let's draw the left side of the heart vessel like this. Okay. Or not the vessel. Let's draw the internal structure of the left side of the heart. Okay, there's your atrium, there's your ventricle. Yay! Here's the thickness of the heart. What happens if this heart muscle here? What happens if this heart muscle gets thicker? Which way is it going to grow? Well, it's going to grow. Let me just do something really right here. Let me get my highlighter here. Ink color. Let's change to black. Okay. So what happens if this side of the heart were to get, this side of the heart muscle were to get stronger, would to thicken, would to get better? You're thinking, that's a stronger heart, right? Watch what happens. Pay close attention in here. The heart muscle will grow this way. It will get thicker here on the outside. And you're still looking at this going, what the hell's wrong with that, dude? But guess which way it also grows? That way. It grows equally in both directions, out towards the outside of the heart and in towards these little areas. Guess what it's going to do? If this heart muscle gets thicker, if all this heart muscle gets thicker in here, what are you essentially losing right now? It's got thicker everywhere. We see black. We are getting thicker and thicker heart muscle. Here, I'm going to do it. It gets thicker, it gets thicker, it gets thicker, it gets thicker. What's happening right now? How much? And remember, this is all new heart thickness that's happened right here, right? Let me just finish coloring this in. This is going to be taking, oh, you're going to go, this is taking a long time. Okay, so let me go back to my laser pointer. Now, look at what's happened in here. How much volume do you have in that heart, that left ventricle? Not a hell of a lot, right? Not as much as you had when we started this little Stilly diagram, did we? We just lost a whole, when it grows in towards the center, in towards the ventricles, what we end up getting is we end up getting a smaller volume that we can move. So you know what the heart does? The heart tries to increase the heart starts to lose cardiac output because the volume inside the ventricle gets decreased. So what does that mean? That means that the heart's going to try and pump harder and faster and harder and faster. And if it keeps pumping harder and faster, you know what it's going to do? And it's working harder, it's going to thicken even more. And it's going to get thicker, and it's going to get into a downward spiral. The more it thickens, the harder it has to pump. So this is where hypertension is a bad thing. The left side of the heart is pumping out blood to the rest of the vasculature. If the ventricle has to work harder to pump out more blood, the heart wall will thicken in the ventricle, not only towards the outside, but in towards the inside of the ventricle. That will reduce the amount of available volume that the left ventricle can pump out. That's going to mean the heart has to work harder, has to work faster. You're going to get increased heart muscle. You get into a downward spiral here to the point where you will get to a point where there is so little cardiac output that the patient unfortunately dies. So that is your left ventricular hypertrophy. It's not good. So that's what happens on to target organs on the heart. On the brain, we already talked about this in cardio and cerebrovascular. You can have TIAs, small strokes, or you can have a full-blown one. It can also lead to dementia. We talked about dementia. Okay, if you have cardiac disease and bad perfused brain, you will exhibit signs of dementia. If you have, on the kidneys, the target organ damage will be sclerosis of the nephrons of the kidney, which we'll talk about when, in particular, how that happens when we talk about kidney disease. But right here, when Okay, diagnosis and treatment. So repeated BP measurements. So we do BPs over and over, and we'll talk a little bit more about this in pharmacology. Labs and X-rays are done to exclude a secondary hypertension. Okay, meaning we want to know if this is primary hypertension. Great, let's just treat you and make sure we don't cause any more damage. But we have to make sure that if we get somebody who has a rapid onset of hypertension, we have to worry, is it because the kidneys are failing? Is it because there's something else going on? Is it because there's a cardiac malformation? What's going on that we started to get hypertension this bad? So labs and X-rays are done to exclude, meaning to rule out any other sort of source of this hypertension. Treatment you'll talk about in pharmacology class. There's going to be pharmacological and non-pharmacological, and you'll talk about which one to choose in pharmacology. And pretty much for this, it's always early and proper screening that is the number one thing to try and do. Some complications are you can have a hypertensive crisis. I mean, the blood pressure gets way too high. It's usually marked by a BP accompanied with progressive target organ damage very rapidly. We're not talking about over months and years here. We're talking over hours and days. And it usually happens when the systolic gets greater than 180 and the diastolic gets greater than 120. And you can also get, with this, a hypertensive crisis, severe headache and dyspnea. So this is what the kid had that I had. I think he had, like I said, on the weekend, he had something ridiculous like 160 or 180 over 110 for a kid, which is considered to be a hypertensive crisis. And usually, if you get the severe headache and dyspnea, it's usually caused by an arterial spasm in the arteries in the brain, and it can cause cerebral edema. Treatment: partial reduction of the BP to a safer level. There are some patients that are special in here. We have something called if it occurs only in pregnancy, and you could say, high blood pressure due to a pregnancy is secondary, right? In pregnancy, we have something called preeclampsia or eclampsia that happens in pregnancy. That's what we call hypertension due to a pregnancy. In children and adolescents, it's primarily due to bad lifestyle. It will. And when we see it as a secondary disease, it's usually due to kidney abnormalities is where we usually see it, or sometimes the only thing that we haven't listed here is sometimes due to something called pulmonary stenosis, which means that there's a thickening or hardening of the vessels leading to the lungs, and possibly even thickening in patients who have cystic fibrosis and stiffening of their lung tissue. We will see it secondary in those as well. But number one on the hit parade is usually kidney abnormalities in children and adolescents. In older adults, it's just getting older and getting atherosclerosis. Orthostatic hypotension occurs when somebody goes, so hypotension, so this is not hypertension. There's no such thing as orthostatic hypertension, or at least not I've encountered. But we just need to make you aware, since we were talking about hypertension, we have to let you know of something called hypotension that can occur when somebody goes from lying to standing, and you will see this in your patients. Okay, it's an abnormal drop in BP when somebody goes from the lying to standing position, and this is because of a lack of reflexes or the ability of the body to accommodate in the peripheral resistance to keep your blood from sitting in your feet, okay, and not getting up to your brain. So the causes are usually reduced blood volume. So sometimes somebody who is dehydrated, if they stand up too quickly because of the reduced blood volume, their brain doesn't perfuse and they feel like they're going to pass out. You can get drug-induced hypotension. You'll talk about that in pharmacology. When you're going to talk about angina medications, you got to be careful. Those ones can cause orthostatic hypotension. They stand up, and those medications have side effects of affecting the vascular resistance and the ability of the body to accommodate from going from lying to standing, and that is going to be that's going to be a adverse effect that shows up in pharmacology. Aging, I'm getting older, and also bed rest and immobility can cause orthostatic hypotension as well. Okay, so pull out your lecture notes for the now for myocardial infarction. Okay, this is what we're going to talk about. And when we talk about coronary artery disease itself, we're going to talk about a couple of things. And so you have to know these big major branches right here. Okay, these are important big branches, what they're coming off of. All right, because in some situations, if you have coronary artery disease in some of these smaller branches, it's not as bad. Remember that concept I talked about, and this is why I did the cerebrovascular lecture first. The lower areas over here, right? If you have a blockage over here, how much area of tissue are you going to cut off? Not as much. What if I have a blockage up here? How much tissue am I going to cut off? Look downstream. Oh crap. That's a lot of heart tissue that is going to be affected if I have a blockage up here as opposed to a blockage down here. So these descending branches down here of the left coronary artery, and it's circumflex. Circumflex means it comes around the back. So this is the front of the heart. This is the back of this heart right here. Just take that heart and flip it over and look on the back, and we see that the left coronary circumflex comes around like this, and then we will see it come over here onto the other side and curve around. Okay, and then you also have the right coronary artery as well. So coronary artery disease, now take a note, I know you don't have these pictures here, but just look at the concept. I sort of started it on the other page. Let's look at the left coronary artery where most MIs usually occur in. If we have a narrowing, if we have a little blockage like this, right? Coronary artery disease is caused by impairment of blood flow. Atherosclerosis is the most common cause. We said that atherosclerosis can happen in any blood vessel, right? If we have 30% blockage down here, and what's that going to do? Well, what's it going to do? It's going to reduce the amount of blood that can go. But what if you're just sitting there on your ass doing nothing? You're sitting in your chair right now staring at this. Is your heart working as hard as it should? Or not as hard as it should? Is it working as hard as it can? Of course not. Okay? Get up and start running around. Is your heart working harder? Yes. It's working harder to supply tissues with more blood. But remember, the heart is working harder too. So it needs more blood. So where these blockages, like a 30% or a 50% blockage, might be asymptomatic while you're sitting on your butt doing nothing, if you start to do vigorous activity and you start having chest pain, well, that's because guess what? You need 100% blood flow, and 30% of it is not going to happen. Your heart needs to work at its entire capacity, and therefore it needs all the blood it can get. Okay? It needs for its blood vessels to be working at 100% to keep that heart muscle completely perfused. If you start blocking off 30%, 50% of that blood flow when you are active, then that is where a lot of these coronary artery disease issues start to make a big deal. And we can have 30% blockage, 50%, we can have even up to 99%. That's not good. Anybody's pushing 90 and 99% blockage, they're having constant problems. Okay? Whereas a person who has 50 or 30% blockage might not have issues when they are at rest, okay, or not making the heart work as much. So apply that idea that we just learned in atherosclerosis to this lecture. So the pathogenesis of coronary artery disease. So coronary artery disease does not produce symptoms until it's advanced because of we talked about collateral blood flow, where you have other vessels coming off from that are not occluded, but they send little tributaries or little blood vessels to help that tissue. So this is how it becomes insidious, and it is asymptomatic for a period of time. Okay, location of where there's going to be a location of significant lesions tend to locate in the first few centimeters. Lesion meaning atherosclerotic plaques, lesions in the blood vessels. So those lesions happen in the first several centimeters of the left coronary descending and the left circumflex, and the entire length of the right coronary artery. So that's why you got to know these two. Coronary artery disease, in the previous bunch of slides, we just talked about reducing blood flow, right? Well, we didn't talk about how. There's different ways you can reduce blood flow and cause problems. Okay? We can have two types of coronary artery disease. We can have acute coronary syndromes. Acute, meaning popped up. Okay? These are caused by acute plaque disruption. They can range from unstable angina to a full-blown MI, myocardial infarction. And then you have chronic ischemic heart disease, which we will talk about, which can cause some sort of obstruction of coronary arteries. Usually it's stable angina is what we're talking about here. And you're going, hey, aren't those both bad? Yes, but one is causing an immediate damage and possibly death to cardiac muscle. The other one is manageable. Okay, we'll talk about this in the next couple of slides. So, we call it that plaque that we talked about in atherosclerosis as this shoulder consisting of macrophages, smooth muscle cells, and lymphocytes. There's a central core laden with with debris. If you have a rupture or an erosion of any unstable fibrous cap, it can lead to a hemorrhage. Because remember we said back you could have one of two things occur. One, this could rip open and you could spill the contents into the central lated lipid core can spill into the blood vessels, and then as it can go downstream, it could cause a clot. The other thing that can happen too is if a cap erodes and breaks, there's going to be bleeding that is going to occur. And if it leads to a hemorrhage, then you're going to get a thrombosis, or in other words, a clot form, because your body wants to stop the bleeding. So this breaks, there's bleeding, the body says, let's stop it. So it tries to make a clot there. Well, guess what? It's making a clot in an area where there's already look at this. This is almost like cutting off half of the whole blood flow. So if you make a clot to try and block off this blood flow, to try and stop this bleeding, you're going to disrupt the whole vessel. Okay, so this is where it can lead that the biggest risk from a plaque breaking is the creation of a hemorrhage, and then creating a thrombotic occlusion, so a thrombus, basically a clot coming from that hemorrhage. Now, take this one step over into pharmacology. You will talk about the use of taking 81 milligram aspirin might save your life. Why? Well, if you look at aspirin is a very good antiplatelet. What's the first step in creating a clot? Think about it for a second. Platelets. Okay, you need platelets to start the whole process of making a clot. If you have an antiplatelet on board, guess what it stops it from doing? Creating more clot. So, pathogenesis of coronary artery disease. We'll have two things. We'll have a stable plaque, one that does not break. It's just getting thicker, but it has a nice, as we talked about in the atherosclerosis lecture, a nice stable cap on it that does not want to break. We end up having what's called stable angina, and you just end up having a narrowing of the artery that becomes worsened usually when activity is happening. If we have an unstable plaque, one that could break open, we end up getting a plaque disruption. That could mean that you could have its contents spilled, or you can have platelet aggregation because of that disruption. A thrombus forms, and then you have and then if that thrombus completely blocks off blood flow, then you have an MI. If it is a small thrombus that just then decreases the narrowing of the artery even more, and this goes off and on and off and on, then you have what's called an unstable angina. So let's look at this. If we have, okay, and we're just look at the top diagram right here. Perfectly good, right? No problem here. Perfect vessel. Let's take this vessel and cause some damage to it over here. We have some plaque to it. You have still about 80 to 90% blood flow there. You have a fixed stable atherosclerotic plaque, a stable angina maybe. Okay, this stable angina, well, what's the worst part about this? It's not going to break open. What is the worst part about this? You have maybe up to about 50% blood flow decreased. So this blood vessel will only operate at 50% of its capacity. Now you go outside, you work in the cold, you start shoveling or whatever, and you start getting chest pain because this blood vessel cannot provide the extra blood that you need for the level of activity of the heart. That's your stable angina. You sit down, you stop work, you stop the exercise, the pain goes away. Now let's look at what happens if we go down here to what's called that's the first part, that's stable angina. Now let's take this to one step further. We have an unstable plaque. Okay, we can have an unstable angina where you keep getting more and more aggregation. We have a disruption here, but does it completely block everything off? No. You just get a buildup. You get a disruption. You get some platelet aggregation there. What's the difference between this one and this one? Well, it's removed a little bit more volume. Okay, but does it block everything off here? No. So that's an unstable angina where you end up getting some pain, but you don't get a complete blockage occurring. We can then have an MI where a thrombus starts to build up. If a thrombus builds up, notice we've got platelet aggregation here, platelet aggregation there, right? But what if we have a thrombus that starts to build and grow on that platelet aggregation? That is when we start getting this is when we start getting an MI, myocardial infarction, because if it keeps going and growing, it'll grow to the point where it's a complete obstruction, and then tissue will go ischemic. So that is the difference between an MI and an unstable angina. An MI has some platelet aggregation, but with no complete blockage, with no thrombus. Okay, and no risk of completely blocking off blood flow. In an MI, there's two types: a non-ST elevated and ST elevated one. Look at the difference. Look, because we're going to talk about this in the next two slides. Non-ST segment elevation MI, ST segment elevated MI. What's the difference between these two? Complete and utter blood flow blockage. Not quite there to a complete blockage yet, but close. Okay, so it's unstable angina, platelet aggregation, no thrombus. MI, you have a thrombus. Then you have two types of MIs. You have an non-ST elevated and an ST elevated one. The difference between these two: partial thrombus clot, partial blockage due to a thrombus, complete blockage due to a thrombus. Keep that in mind. Let's go to the next slides. So pathophysiology, we have occlusion of arteries. Okay, the contractility stops after several minutes, depriving the myocardial cells of glucose for aerobic metabolism and oxygen. Lactic acid builds up. Okay, and we end up getting myocardial fibers are irritated by the lactic acid, and we end up getting pain. And anginas can lead to an MI, either due to an unstable angina or to a over time where the angina gets to the point where it or the atherosclerotic plaque builds up so much that it actually starts impeding blood flow. I just like this one. Read it for a second. You can't hear very well. No, I just said I've got to. Never mind. If you're not laughing, then you need to get some coffee. 3 types of angina. We said that when we have 3 types of angina, we have something called stable angina. This is when you have pain when the heart's oxygen demand increases. Old man goes out and starts to shovel snow, like tomorrow, like Wednesday, it's going to snow again. And he starts to shovel snow and he increases his activity, and guess what? He starts to have pain. Why? Because that blood vessel with that stable plaque is unable to increase blood flow because there is a partial blockage of the blood flow. You cannot use that blood vessel to 100% capacity. We have this other one called a variant anginal, which is pain that occurs when the coronary arteries spasm. So you might not necessarily have a atherosclerotic plaque, but for some reason you have the vessels spasm and contract when they're not supposed to. And if they do that, then you can end up having decreased blood flow, which leads to inguinal pain. And there is even one called a silent myocardial ischemia, which basically means some ischemia without pain. I know. How do you figure out he's got angina if he's not having pain? I don't know. It's a doctor thing. But these are the two. So stable angina, this one primarily comes with atherosclerosis. This one comes when the blood vessels, either with or without atherosclerosis, basically have a spasm. That's the big defining difference between these two. Okay. Variant angina is due to a corneal artery spasm, okay, with or without atherosclerosis. A stable angina is primarily due to decreasing blood flow and having increased oxygen demand that that vessel cannot appreciate to. Let's look a little bit more at chronic stable angina. Usually we call this angina pectoralis. It's a sudden attack of chest pain with chest pain due to transient myocardial ischemia. Call it transient because it can get better. Just stop doing the extra workout or whatever and it goes away. So there is usually what we call a fixed coronary artery obstruction, where the blood flow is insufficient to meet the metabolic demands of the heart. Very associated with atherosclerosis most of the time. Usually triggered by increased work demands, okay, as I kept using the example of going out and shoveling the snow. The primary manifestation is pain, usually chest pain. Steady. It's usually a steady pattern. There's a constricting sort of feeling or squeezing, suffocation sort of sensation that happens. It's usually in the substernal area, not sternal, substernal, so lower than the sternal areas. It can radiate, these are the classic ones, radiate to the left shoulder, jaw, or other areas of the chest. And there's usually relief after 5 or 10 minutes, as you're going to find out in pharmacology, with some sort of nitroglycerin. You'll talk about the different various nitroglycerins in pharmacology, but here you just need to know it's nitro. Okay. The thing is, if it's longer than 5 or 10 minutes or the nitroglycerin does not work, then you have another problem. Okay, then you have a different event going on. So if it resolves with, if it's longer than 5 to 10, if it's longer than 5 to 10 minutes for relief, the pain is not due to ischemia or due to or is due to ischemia or severe ischemia. Diagnosis. So diagnosis is interesting. We do what's called an exercise stress test. So we stick you on this. First of all, we do a detailed history always. We rule out non-coronary causes. You will see some changes happen on an ECG if you make the person work. So the non-invasive test that you do is you stick them on a treadmill. You increase the height of this use the height of the incline right here, have them work harder and harder and harder, and as they steadily increase the work, you see changes on their ECG. And then you stop the work, and guess what? It goes back to normal. That's called an exercise stress test. So that will tell them that they have angina. They can also do echocardiography, some nuclear imaging. They can do a CT and an MRI. And pretty much the definitive diagnosis is when they stick a catheter in. And look at this little picture right here. This is a blood vessel, and it should have a nice, slow, gradual, narrow. It should get narrower, narrower, narrower until it gets to the very bottom. But look how it pinches in right here. Okay, it's thick over here, and then it pinches in, and then it's thick over here. Well, that tells you have a narrowing of the artery. That is your angina. And usually cardiac catheterization, or what we call coronary angiography, where we actually map all these ones, will tell us where we're actually having problems and where we have the angina occurring. Treatment. We're not going to get into, as I said, we don't get into the types of medications, their specific names. We just talk about their different class categories. Other than class categories, nothing else we will talk about. So treatment non-pharmacological is reduce your risk factor, eat better, stop doing all the crappy stuff you're doing, stop smoking, okay, and control your symptoms as well. The pharmacology, there's going to be 3 categories of drugs that we will use: nitrates, beta blockers, and calcium channel blockers. You will learn the individual ones in pharmacology. We can do some interventions for those who are getting angina that is becoming more persistent, and it's something called CABG, coronary artery bypass graft, for people with and with sometimes double or triple vessel disease. If you have, so that means that on the same vessel that you have 3 pinching endpoints. Well, guess what? That's really not good. Okay, so if you can go coronary artery bypass graft, can be done to actually bypass the pinched in areas and increase full blood flow. Now, we're going to get into, from angina, we're going to talk about myocardial infarction. Oh my God, do we have to, sir, do we have to know how to identify the ECGs? No, I'm not going to give you an ECG strip and tell you to identify it. What we will give you is probably one of these things on a test and ask you to identify which one is bad. Why? What is this showing you? Well, we're going to talk about the difference between a STEMI and a non-STEMI. So let's talk about what this means now when we're talking about coronary artery disease, or an MI. Okay, this isn't as hard as you think it might be. So with this, when we have coronary artery, so we have acute coronary artery symptom, which means something that happens quite quickly, and represents an acute ischemic disease, specifically like we call it a myocardial infarction, heart attack. The ACS, or acute coronary syndrome, is classified based on the presence or absence of something called an ST segment elevation on your ECG. We're talking about, when we go to anatomy, ST segment of that ECG, where it's either raised or not raised. That's it. That's as hard as that's going to get. We'll show you in a couple of slides. Basically, it guides whether or not a person should be considered for acute reperfusion therapy. What the hell is acute reperfusion therapy? It basically means, now, don't make the mistake here that a non-STEMI or a STEMI, that they're both okay, that one's okay and one's not. No. Both need to be treated, but one needs to be treated for, we say, reperfusion therapy immediately. We're talking the magical 20 minutes to an hour to get thy ass to, excuse me for swearing, but to get thyself to an emergency room because cardiac tissue is dying. Okay? If you have a STEMI, you got to fix it quick. Okay? If you have a non-STEMI, you have a little bit more time to play with. Okay? And the big thing that we're going to talk about in the difference between a STEMI and a non-STEMI is, in a STEMI you have complete and utter blockage, complete and utter lack of blood flow to coronary tissue. In a non-STEMI, you still have some blood flow. Go back a bunch of slides to when we looked at those blood vessels and level of occlusion. You'll see that I said the myocardial infarctions, okay, different from an unstable angina, had a thrombus. And the non-STEMI had a thrombus, but it wasn't completely occluding the vessel. A STEMI had complete occlusion of a blood vessel due to a thrombus. So that's where we have to make the differentiation. One is, you need treatment for both, but one, you need really super fast treatment. Reperfusion therapy we'll talk about, and we put a whole bunch of links to the University of Toronto's website on reperfusion therapy, and you can go watch and see how those things are done. Okay, if you want to see how they're done, they're very quick little videos. But we'll also use, to figure out how to do this, serum biomarkers will also be used to, so as I said, you can have 2 types of MIs. And the ECG, this is the classic way of figuring out whether or not you're having an MI. And the classic changes that occurred with an acute coronary syndrome include a T-wave inversion, an ST elevation, or the development of an abnormal Q wave. Remember, ACS, you can have STEMI or non-STEMI. So these are just referring to all the possibilities you could see with just an ACS. Under an ACS, you have STEMI and non-STEMI. Okay, changes in electrical function will occur as well, depending on how long and how much blood flow is occluded to occluded to the blood vessels, or occluded to the heart muscle. Excuse me. And when somebody has this, it's basically you need continual, or what we call continuous ECG monitoring, or serial ECG monitoring, meaning they have to basically be on an ECG monitor the complete time. This is where you would see this if you're in clinical and you're going to a telemetry floor where everybody is walking around hooked up to some sort of remote cardiac monitor. Now, this is what you're going to remember back to anatomy, okay? This silly thing right here, okay, refers to what is occurring over the basis of the heart. The P wave means that you have the electrical activity sweeping over the atrium. The QRS basically means that you have the ventricles going through their phases right now, and then the T wave is your recovery. So if we have an ST problem here, ST segment right in here, that means there's something going on between here and here, doesn't it? And that sort of fits, doesn't it? That sort of fits with what we were talking about when we're saying, guess what these are doing? The P wave is up here, right? And then down here, if we have problems with we're going to see problems in the S and the T segment, and this is and again, the T wave is here. So let's go to the next slide and talk about those. Oh my God. What's wrong with this? Oh my God. Look at non-STEMI. So here we have normal. So we have all four things here. We have a normal heart. This is a normal rhythm from anatomy. That's normal. See, it says normal, normal. This one right here is normal. If we have a STEMI, what do we see? The ST segment elevated. Look at this section in here. Look, it just increases. We see it elevated, and we see it does not come back down here and then go into our little thing. We see that the S and the T wave stay high, 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 and then when you get through the end of the T wave, then it drops. This means complete occlusion of blood to myocardial tissue. That's why we call it ST elevated myocardial infarction. ST meaning ST segment elevated MI, myocardial infarction. That's what STEMI stands for. Okay? We have, and there's only one that looks like this. Would we be able to put one of these four or all three of these on a test? Hell yes. This is the only diagram we would probably give you. Okay? So you can actually put the pathology and the anatomy together. Okay? This is bad. Reperfusion right away. There are two possibilities for a non-STEMI. In a non-STEMI, you can see ST depression, meaning it's going further in its recovery, or you can see the T wave here get flipped. Okay, so there's a difference between these two. Aren't as worrisome. They still need to be treated. Don't get me wrong. It's not like you're going, oh, I'm fine, it's a non-STEMI, I can go back home. No, you're still going to the hospital. But the difference is the STEMI, you're being taken to the hospital, you bypass the emergency room, you go straight up to a catheter perfusion unit or cardiac care unit, and they start working on you immediately. You don't even go to the emergency room, they take you right upstairs. These ones, you go to the emergency room, they check you out, they admit you upstairs, they keep you monitored, and then they make a plan to happen over the next several hours or several days. Okay, so that's the difference. This is still an acute cardiac episode, but it is not as it doesn't need as immediate treatment as this one right here. This one you have myocardial tissue dying as time goes on. So when we look at this as well, as you can see, when we look at we have normal here with an ST elevation, and sometimes it gets a little bit wider as well. This is where we see, if we see that we have ST depression, we have an injury going here, right? Just partial of the wall gets ischemic. If we have ST elevation, what we have is the entire thickness of the wall of the heart wall. This is the bottom of the heart right here. This is right ventricle, left ventricle, right ventricle, left ventricle, just looking at the bottom. What we have here is when we have ST elevation, what that gets transferred, that's what it represents is a complete complete injury to the cardiac muscle, or we said transmural epicardial injury, which means injury from one side completely to the other side. When we have ST depression, which occurs in a non-STEMI, we end up having just partial damage occurring, not the full thickness of the heart muscle. That is the difference between, another difference between a STEMI and non-STEMI. I said complete heart muscle is dying. Heart muscle's been damaged, okay, but it's not a complete damage across the entire thickness of the heart muscle. You have room for recovery here. You don't have room for recovery here. You're in big trouble, okay? So diagnosis, when we look at some of the serum biomarkers, troponin 1 and troponin T are the two biggies that tell us that you're having some sort of ACS going on. And there's also two other ones called myoglobin creatinine and what we call creatinine kinase, or what we call creatinine kinase MB, or in other words, short form CKMB. What these are evidence of, these are evidence of tissue dying. Okay, or to some degree. As myocardial tissues die, they basically rupture, they explode, and their contents drift into your bloodstream. So that's what this means. As the myocardial cells die, their intracellular contents basically begin to diffuse, or basically ooze into the interstitial space and then into the blood. And then enzymes then need to remove them because they're considered foreign matter in the blood. So what we're measuring is we're measuring these biomarkers. These are markers that either measure the enzymes or the actual components that have oozed into the blood. The troponin assays, these ones are highly specific. If you've got troponin going on in your bloodstream, you've had some cell damage to your heart muscles. It's highly specific for myocardial tissue damage. So this is number one, damage has occurred. It's the primary biomarker to tell us whether or not you've had a myocardial infarction. And the reason being is it's part of the troponin, it's part of the muscle fiber of the cardiac muscle. So if we see troponin shouldn't just be floating around in your bloodstream. Heart muscle dies, troponin will float around in your bloodstream because the internal components got dumped in there. And this usually happens within 3 hours of having an MI. You will start to see those numbers go up. Can stay elevated by 7 to 10 days. It's useful for late diagnosis as well. Now, the CKMB, this is, look at this, it is an isoenzyme. Remember on the previous one we said either the contents or some of the enzymes to remove those contents are what are going to be used, or is what we're actually measuring here. So it's an isoenzyme specific injury to myocardial tissue. This is the enzyme you need to help remove some of this garbage, and garbage like it. And it usually gets elevated 4 to 8 hours. Oh, so guess what? This one raises 3 hours afterwards. That means this one's going to raise 4 hours afterwards. Now that you started to dump all the crap in your bloodstream, now you got to start, your body has to activate itself to remove that crap. So that's where you get CKMB, which is the enzyme that helps to resolve the foreign components that are in your bloodstream from cardiac tissue death. And this one will start to return to normal after 2 to 3 days, okay? Because it's basically just going to bring it down to a level where it's so let's look at these again. I just dozed off there for a second, but I'm back. So pattern changes in ECG biomarkers. So look what we see here. We have unstable angina, we have some myocyte necrosis. That is something we will see here, but this is what's interesting here. The troponin can come up and stay elevated for several days up to here. A CKMB, okay, will start to elevate with an hour after this one's begins, so about 4 hours afterwards, and can stay elevated for a couple of days, where the troponin can stay elevated for like almost up to a week. All right, let's look at myocardial infarction a little bit closer again. Let's look at these two things. Let's put a little bit of this together. Unstable angina. Okay, so unstable angina, pain at rest, new onset of pain for within the last month or more. It's frequent pain. There's the difference here. Think about this. Unstable angina, a non-STEMI. No serum biomarker changes. Go back a couple of slides. Okay, look at those slides I showed you where we looked at STEMI versus non-STEMI and where the tissue damage was. Unstable angina, you have ischemic cells in the, you don't have a transmural or a complete damage across all of the cardiac muscle. You have an ischemic episode usually on the inner portions of the heart. That's not going to translate into significant amounts of biomarker changes when you have unstable angina. Okay, and angina is basically you're going partially ischemic and your heart goes, it hurts, it's painful. But do you have tissue death there? No. We said with angina, okay, we said with angina that you've got decreased blood flow, it doesn't get enough sugar, and you get lactic acid buildup. Okay, everybody knows what lactic acid buildup feels like when they get muscle cramping and everything after a workout. That's because you didn't have enough glucose and you got lactic acid. Is that causing muscle death when you have sore muscles after a workout? No, it doesn't cause cell death. So in an unstable angina, you do not have cell death. That's why you do not have any biomarkers. In a non-STEMI, like I said, go back, look at that, pull out that slide that we were just looking at a couple of slides back. In a non-STEMI, we have some cardiac death. Not a lot. It's not transmural. Okay, so in a non-STEMI, we have sufficient myocardial damage to decrease some detectable quantities of troponin. Half the thickness of the heart muscle has some damage to it, so we are going to see some troponin released. Unstable angina, no death of cell tissue. STEMI, some death of cell tissue. Okay, guess what a STEMI is going to do? Complete death, a lot of death, transmural death of the cardiac tissue. Okay, so this is where we're looking at in this slide right here. What is just happening between unstable angina and a non-STEMI? The difference between the two is on these two slides. Troponin is released in a non-STEMI, detectable quantities. No serum biomarker changes in unstable angina. Treatment. Before we get into a STEMI, treatment for unstable angina or non-STEMI, for either one of these two, is basically decrease the platelet aggregation and decrease the workload of the heart and let the heart heal itself. Drugs. ASA, beta blockers, ACE inhibitors, nitrates. That's what we're going to do. They may, depending on the number of narrowings, angina narrowings that happens in the heart, we might see that they might do some coronary bypass, or they might do what's called percutaneous coronary intervention, where they actually go in and modify the blood vessels. It depends on the level, how bad it actually is. Again, looking at this right here, here's your normal blood flow. Here is your non-STEM. Here's a non-STEMI. Here's your STEMI. Here's your STEMI, complete blockage with a clot, right? This could even be seen as possibly a stable angina, right? Or this could be a non-STEMI or a stable angina. This one right here, this is definitely a STEMI. You have a clot with platelet more formation and contents. Now, an ST elevated myocardial infarction. There is ischemic death going on. Okay, there is a large size and pattern of an infarct, depends on the location, depends on the vessel that's occluded, it depends on how much of the heart muscle then is supplied by that vessel. It depends on the metabolic needs based of that tissue, and it depends also on the extent of the collateral circulation. And we are going to see changes in heart rate, blood pressure, and cardiac rhythm. This is that non-STEMI that we were looking at. So this is the same slide that I had right at the very beginning, and this is what we're talking about right here, non-STEMI. Or sorry, we're talking about a STEMI. We've already talked about the non-STEMIs. Now we're going to talk about what we do about the STEMI. So the unstable, if we have an unstable angina that leads to a STEMI, or so slight review right here. So the unstable angina or the non-STEMI, the one that does not, where we get unstable angina, we end up getting no biomarkers, some detectable biomarkers. It usually is categorized by one of the following. It occurs at rest with minimal exertion, as that severe frank pain. It can become more severe and prolonged and frequent. And when we compare that to a STEMI, what are we having here? So comparison. So that's why that last slide was just there on the previous, where we said, why are you talking about non-STEMI again? Keep that in mind as you're looking at what happens in the STEMI and the pathology of the STEMI. Okay, metabolic changes from aerobic and anaerobic with inadequate energy production to sustain myocardial function. There is a striking loss in contractile function of the heart, which means your cardiac output is going to drop. Cell structure changes within minutes. Ischemic area ceases to function within minutes. Irreversible cardiac death occurs in 20 to 40 minutes with severe ischemia. So that 100% blockage, you're going to have cell death, permanent cell death, within 20 or 40 minutes. This is why with a STEMI, we want to get reperfused as quickly as possible. So the reperfusion, now, I did this for you guys when I talked about cerebrovascular disease, and I want you to go back into your brain and pull that out from it. Remember I talked about the concept of a penumbria, right? Where there's a portion of tissue that is not completely obstructed of blood flow. There's a part which is dead in the middle, and then there's a part that is, if it continues on, will suffer more damage and will get worse and worse. Well, this is the whole goal of reperfusion, to establish blood flow using one of two things, using pharmacological therapy, which you guys will talk about in pharmacology, TNK, fibrinolytic therapy, or some sort of operational revascularization process. So that's what reperfusion, get the blood back flowing again. The early benefits of this is it prevents further necrosis, or if it's caught early enough, hey, you have a heart attack right out in front of St. Mike's Hospital and walk into their emergency room and say, I'm having a heart attack, and they get you upstairs in 5 minutes. Well, what did we say on the previous slide? 20 to 40 minutes. They get reperfusion within 20 minutes. Good for you, man. You might be okay. But the benefits is it could prevent complete necrosis, or it can improve myocardial confusion to the infarct zone, may also prevent further microvascular injury from occurring. There will be some abnormalities even in the best situations, but what we want to do is we want to get that stunned myocardium, the area that has lost vasculature, lost perfusion, but has not completely died. That area is going to be stunned. It's going to be needing to recover. So reperfusion is the goal of when we have a STEMI, to prevent further damage and to try and reverse any reversible damage that can occur to areas that have not had 100% blood loss yet. So clinical manifestations, this one is basically take your non-STEMI up notch. Severe and crushing pain, usually substernal radiating to the left neck or jaw. Pain is not relieved by rest. Women have atypical ischemic symptoms. Elderly usually complain of shortness of breath. I think I have this video here. I think this is the video of why women are different and what things that will happen different in women. And I'll make sure that I have that, guys, for you to click on outside of on Blackboard. Other clinical manifestations, there can be some gastrointestinal complaints with acute MI, epigastric distress, fatigue and weakness, pain and sympathetic stimulation causing tachycardia, anxiety, restlessness, a sense of impending doom. Oh my God, I'm dying! Those sort of things. Their skin color, they will be pale, cool, and moist. And when we diagnose an acute myocardial infarction, that's what AMI stands for, which is basically a STEMI. The crucial recognition is that we recognize the symptoms of when somebody is starting with it, because the one thing that is occurring that the thrombus will grow to the point where it's 100% occlusion. Okay, so if you know the symptoms right away, this is why they say eat 81 milligram tablet of aspirin. What will that do? It will prevent the the thrombus from getting to complete occlusion. Okay, but the symptoms of it will start as the thrombus grows to the point where it will start to completely occlude the blood vessel. So recognizing those symptomatologies so that you can get therapy right away, whether or not it's eating an aspirin and running to the emergency room or just running to the emergency room, or calling an ambulance. They'll also need ECG monitoring, usually a 12 lead. Prognosis is related to the occurrence of complications. So prognosis, your outcome, how bad is your outcome? Well, it depends on how much frickin' tissue you damaged. That's the bottom line. The one thing that usually occurs is some sort of arrhythmia may occur from the cell death, and there may be some mechanical complications. So left-sided, right-sided heart failure due to a MI. So this is where an MI can lead to, go to the other lecture that Annagale is talking about, myocardial, or talking about heart failure. One of the things that can lead to heart failure is somebody who has had an acute MI where the damage has been in a certain area that causes failure of the right side or the left side of the heart to pump properly. Do I need to know this? Sure. Hell yes. So we call this the circle of treatment. Okay. There are certain things you need to treat an MI. Oxygen. Why do you need oxygen? Well, because you want to increase the amount of oxygen, as much oxygen as possible, to try and keep the tissues going. So you want to increase the level of oxygen, and oxygen isn't going to hurt them. So they need oxygen. They need aspirin, ASA, which you should know about in pharmacology, and why? Because it's an antiplatelet. Stop the thrombus from getting any bigger. Why do we need nitrates? What do the nitrates do from pharmacology? The nitrates are going to dilate the blood vessels. Okay, great. So we're stopping so oxygen. Why? Maximize the benefit of that blood. Let's keep things as oxygenated as possible. Notice these are all connected. So start with oxygen. Then you start with and these two things here, these three things here, this will be given by EMS before you even get to an emergency room, or before you even get to a reperfusion area. So oxygen, aspirin, nitrates to dilate the blood vessels. Let's get more blood. All these things are to get more oxygen to the cardiac muscle. Morphine. Why morphine? Remember anatomy. They're going, oh my God, he's saying that again. Remember anatomy. What did we say pain will do? And remember pathology too. What will pain do? Think to the last lecture on pain, or in pathology. What will happen if you have a high level of pain? Well, you're going to get cardiovascular changes. And remember, this is a hard crushing not vascular. This is a hard crushing internal pain. Okay, people will have vascular changes, their heart rate will go up, all the things that will happen, all the autonomic nervous system changes that will happen because of pain will cause decreased perfusion. So you want to relieve the pain. And then they will also think about some BP meds to further augment the dilation that the nitrates were doing, and then they will think of either, depending on whether it's a STEMI or non-STEMI, or what the final diagnosis is, whether or not you use TNK, which is the streptokinase type of drugs to break up a clot, or the clot-busting medications, whether or not you go in and percutaneous coronary augmentation here, or whether or not you do a coronary bypass. So, persons with EC, this is where the little videos that we've attached will help. Go look at these ones online, and it'll make a lot more sense if you have a visual to go with it. So persons with evidence of a STEMI fibrinolytic therapy, you're talking about that in pharmacology, the percutaneous coronary intervention, or the coronary artery bypass. The fibrinolytic drugs, I won't get too much into it because you're doing it in pharmacology, but basically these are the things that dissolve existing clots. Okay, reduces mortality, limits the infarct size, and encourages myocardial healing. It's usually given with antiplatelet medications. This is your aspirin that you start with, okay, and other antiplatelet medications as well. Antiplatelet just prevents you from making the clot any bigger. Dissolve an existing clot, TNK. Stop the existing clot from getting any bigger. There's your aspirin down here. There's your thrombolytic therapy when you actually get to the hospital. Okay. As I said, go online and look at these as well, and see how these work. These are actually kind of cool. How they actually then can actually crush down some of these flattened plaques, and sometimes they will put in stents that actually sort of literally prop the vessel open. Coronary bypass is basically what it says. They use usually arteries or veins to actually create a new bypass around the blockage. It's as simple as that. It's like coming up on a highway and they say take the neck, bypass onto the parallel highway and come back on and come around the accident. You're doing the same thing as in the heart. And it's usually emergency treatment for a STEMI within 4 to 6 hours of onset, revascularization of the myocardium placed by putting the saphenous vein. The great thing about this now is that we're actually using some arteries instead, which is much, much better because the arteries can handle the pressure better than the saphenous veins. But classically, what it's always been is using a saphenous vein. They're not using that as much anymore. And what they will do is they will literally bypass across the area where the occlusion is, so that you get blood flowing down to the level below where the occlusion is. Now, the myocardial post-infarct recovery period, you will have some changes happening. You'll have the zone of infarct right here. It's dead. Zone of injury around it. Zone of ischemia around that. This is like that penumbra dam thing that we were talking about. Okay? It's the same concept, but with cardiac surgeons, they don't like to use the same word. They use zone of infarction, dead tissue. Zone of injury, which means that it's recoverable. We don't know to what extent. Zone of ischemia is completely recoverable. This is where we want to get reperfusion happening to try and make all this area in here, zone of injury and zone of ischemia. We want to get that to recover as quickly as possible. Some changes that will occur to those areas, and specifically the zone of injury. 2 to 3 days. Inflammation, just like we talked about wound healing before. Inflammation occurs in the necrotic area. Macrophages begin to remove their necrotic tissue. Damaged areas placed with granulation tissue. This sounds like wound healing, doesn't it? It should. Becomes less vascular, more fibrinous. And the center area sometimes softens and turns yellow. Necrotic tissue then, after 7 days, becomes fully replaced with scar tissue that lacks the ability to contract or conduct action potentials. This is where you get your left-sided or right-sided heart failure. Because guess what? If that scar tissue that replaces the necrotic tissue is not contracting the same way, remember, contractility is part of your cardiac output. So the contractility of the heart has been affected by this non-contractible tissue, this non-cardiac tissue, which has died, being replaced with scar tissue. Okay? And that will then can lead to, we said, left or right heart failure. Go to that lecture. And complications that we can have from this: complete heart failure, left or right-sided. You can go into cardiogenic shock. You can have something called pericarditis, which basically means an inflammation in the sac surrounding the heart. You can have more thrombus formations in the heart muscle. That's where the thromboemboli occurs, and those emboli can then be shot to your brain, and off you go to if it's a bad one, then you can have a stroke and potentially expire. You can have a rupture of the heart, so that if that area that is being that dead tissue area, if it's being replaced and it's not replaced with the strongest tissue, then the heart can rupture. If your heart ruptures, you're dead. Hate to say it, but you're not gonna make it to an emergency room if your heart actually ruptures. We can also get some other things called ventricular aneurysms. So aneurysms that's a bulging of the muscle wall of the ventricles. That's due to the improper healing that goes on in scar tissue. A stroke can occur. This is where you can throw an emboli up to your brain. You can get a whole bunch of mechanical defects of the heart, which can lead to congestive heart failure. Mitral valve and left-sided or right-sided heart failure. You can get mitral valve regurgitation, ventral septic rupture, left or left ventricle wall rupture, left ventricle aneurysm. All these things can lead to death and or other manifestations or other illnesses like left or right heart failure.